Hello, good afternoon. This is Velma Scantlebury, and I am here with you live for our DPC Educational Center. Thank you so much for coming on. Hello, this is Dr. Scantlebury, Dr. Velma Scantlebury. I am the medical consultant for Dialysis Patient Citizens Educational Center, and I'm here with you with Ask the Doctor. I know it's a beautiful day here in Delaware. I'm not sure where you are, but if you are like us here, it's in the 90 degrees, and perhaps you are out and about or resting and are on dialysis, but I hope all of you are doing well. And if there are things you would like me to discuss, please let me know. Hey, Arthur, thank you for coming on. Wasn't sure if I had forgotten the day or others had forgotten the day, but this is a live session with Dr. Velma Scantlebury, Dialysis Patient Citizens Education Center, and I am here to discuss any of your topics. I'm not sure where you are, but I know it's pretty warm here in Delaware, and we're expecting a rainy weekend for the holiday weekend. So let me know where you are and if you are on dialysis or a transplant patient, and what questions you may have or what topics you may want to discuss. So I'm here for you. Since you're the only one, we can wait a little while and see if others may want to join. And I hope you and your family are doing well. I am doing well. Besides being the medical consultant here at Dialysis Patient Citizens, I'm also a co-founder of a medical clinic where we work to really meet patients where they are, address their needs, identify the barriers to good health. I have many of my patients are on dialysis. I have a few who are post-transplantation. Just had one who recently just got transplanted with her third kidney transplant, and I've had two patients who actually received a transplant from a hepatitis C donor, and that is now one of the categories that are being used to expand organ donation, because most of the time if a donor is tested positive to hepatitis C, generally if it's a donor that is also have potential to be a liver donor, they will examine the liver to make sure the liver is good. Oftentimes they would biopsy the liver to make sure there's no evidence of scarring, because one of the downsides of hepatitis C is that it can cause significant liver disease and cirrhosis. So oftentimes many of the donors may have the antibody to hepatitis C, but they may not have any virus in their system. They might have had hepatitis C infection before, but now the virus is gone and there's no evidence. But just in case, many of those patients who receive a hepatitis C positive donor will be tested to make sure they do not develop hepatitis C. And many of the programs that have been established will immediately assume that if they turn positive, they will be immediately treated with antiviral agents to combat that virus. And so that is one of the advantages, in that many patients will not turn hepatitis C positive, and therefore we don't want to be necessarily throwing away, getting rid of donors' organs that could be used. Many of these livers are certainly used in liver transplant recipients, because they're dying, and a liver with hepatitis C is certainly much better than no liver at all. So again, welcome Nancy and Deborah for joining. I am Dr. Velma Scantlebury. I am the medical consultant, and I was just talking about the availability of expanded donor organs, especially kidneys, by including organs from donors who are hepatitis C positive, and the fact that that would allow for many more patients to receive a kidney transplant with the really superb monitoring of patients for making sure they do not develop hepatitis C. It's what we call an expanded donor because it's outside the standard criteria, but many of these hepatitis C kidneys are from younger donors, which make them more amenable for longevity, and certainly they may have a high score, but are still worth using because hepatitis C is treatable with all the new antiviral therapies, and we know that we can clear hepatitis C. And this is quite different than hepatitis B. Hepatitis B generally will go dormant in your system, and there are some people who would clear hepatitis B, but there are also people who become chronic carriers, and we're able to really quantify the antigens that are, or the virus, the amount of virus that's in your system. And if that virus persists, then you need to long-term anti-hepatitis B viral treatment that oftentimes will certainly need to be monitored, and for many patients don't go away. So if you know of anyone or who's waiting for a kidney transplant, remember that's an option. They also have what we call other criteria of expanded donor kidneys, which is an area where it's donation after cardiac death. And so that is when the donor has some brainstem function. They're no longer functioning, no cerebral, the big part of your brain, blood flow, but there's still blood flow in the cerebellum, which allows them to breathe on their own. And also when you continue to have breaths, your heart will continue to beat. So those patients taken to the operating room, once the family agrees that there's no hope of recovery, they're taken off the ventilator. They're allowed to pass within that hour. If they do, they're then declared dead, brain dead, meaning there's flat line. And while they're in the OR, we can quickly retrieve those organs and also use them for transplantation because they're within that hour after death. Because remember, even though while they're not breathing, there's no oxygenation. So there will be some cell death, and oftentimes those kidneys will have a slow recovery. Patients may need to be on dialysis for a few days, few weeks, depending on the extent of what happened prior to them becoming a donor. So those are options that are also depend on the age of the donor and other comorbidities. And so Sherry has a question. Hello, doctor. I am in Chicago. The weather here is mild. I've recently been diagnosed with stage 5 kidney disease. I've been on dialysis for 4 weeks now. I'm feeling so tired after dialysis. Is there anything I can do before treatment to help with the fatigue afterwards? Well, remember, your body it's only been 4 weeks, and so your body's getting used to emptying. If you're on, I assume, hemodialysis, it's a change in your system because you're taking all that blood out and they're rinsing it and returning it to your system. Certainly, generally, you want to make sure that you eat before you go to dialysis, but you want to eat too much so you don't get nauseated. Some depending on how other patients react. But yeah, keep your hopes up and try to depending on how much fluid you're taking off. If you're still making urine, is it only for your potassium? Are you really dehydrated afterwards? If at this point it might be for volume, so your body's having shifts of fluid from the intracellular to extracellular. So it's an adjustment of your body, and sometimes it takes time. So hang in there. Make sure you get your rest. Make sure you work with your provider to control your volumes, control your potassium. those kind of things, so that your dialysis treatment can be optimized to the best. Nancy said, discuss treatment options for dialysis patients. Certainly, we probably talked about this before, but when you talk about people with end-stage kidney disease, or to get to stage 5, their function is still able to survive without dialysis. They may be tired because now your eGFR is somewhere between around 15 or even less for some patients. And just remember, if you're not on dialysis and you're thinking about, then they present those options for treatment. Remember, even at that stage 5, you're going to have a lot of fatigue. You're going to oftentimes have memory problems because, one, those metabolites are still in your system. If your function is 15%, just remember 85% of all your metabolites are not being filtered out of your system, and it's being accumulated day after day. So you're only getting 15% out. And so there's an accumulative effect of those waste products, which affect your mental capacity. You keep forgetting, and you're thinking it's so because you're getting sicker. Yes, those things are accumulating in your body. So how do you rinse these metabolites out of your system? 1, replace your kidney if you can, and that means getting on the transplant list. That's the ultimate goal and the gold standard, because that's where you're going to get your creatinine or your kidney function way below 2. You certainly want it down to normal, where you feel normal, your heart is able to adjust, and that's the goal of kidney transplantations. For some people, if you don't have a living donor, or you're at stage 5 and you have a living donor, you can go ahead and work towards getting a kidney donor from that person who's willing to donate to you. It don't have to be a relative, it can be a friend. You have to have some compatibility. Outside of that, it's either dialysis, either through hemodialysis or peritoneal dialysis. Peritoneal dialysis is the one that you put in catheter in your abdomen, and it's filter the metabolites out that way. And then there's hemodialysis, which can either be done in center or at home, and that requires filtration of your blood, where it goes through the machine, and you can do it more what the body tolerates better. At home dialysis 5 or 6 times per week on a daily basis, but you do it in center, you're talking about 3 days a week. That is a lot harder on your system. You're accumulating more. Your body goes into you're draining fluid off every other day, and so that can be even more detrimental to your system, makes you tired, because you just imagine if you were getting rid of waste products or getting rid of being able to go to the bathroom to eliminate your bowel only 3 days a week, but you're eating 3 meals a day. Just remember that that is harder. Is going to be harder to get rid of those metabolites. Tom said, yes, I find my weight goes up if I eat before dialysis and then they try to take it off. Even bowel movements can change the weight and cause wicked cramping. It's a balancing game. Feel best if I gain 0 to 1 kilograms correctly. The more you gain, the more they're going to try to pull off, even though it may not be fluid weight, but they're looking at your weight in kilograms. So certainly you don't want to eat enough to, it depends on if you're doing every other day dialysis, then you may gain more weight. If you're eating heavily and not able to have a bowel movement, then that can be 2 to 3 pounds right there. And so that's not even counted in, but then they're trying to take that weight out. So you really want to make sure you're regular, and that you're not accumulating, you're not too constipated, and you want to minimize your gains. If you minimize your gains, then there's less to pull off, and that will make you in a little bit of equilibrium, because then your body isn't feeling the squeeze so much. Remember, if you gain 3, 4, 5 kilos, then you're going to try to squeeze that off. And people think about kilos, but they think not in pounds. 2.2 pounds is a kilo. So if you gain 4 kilos, that's about 10 pounds. And then you're trying to squeeze that 10 pounds off of your system, and your body then feels like you are a prune, because now you have pull that fluid off just to get rid of the weight, but your cells are saying, I'm dry now, but now your body has to go through an equilibrium to move that fluid back into your system from the cells, where you may have more swelling in your tissues, but you eliminated the fluid out of your bloodstream. And so now it takes a while for that equilibrium to occur. So it's really a balance. And so you want to be able to, if you're making urine, you have a little bit more leeway for balancing out that, because you're also going to lose fluid through your urine. But if you're not making any urine, then all that extra weight has to come off via the dialysis machine. Have you found that support groups can be effective for dialysis patients? Absolutely. Unfortunately, when we're going through, issues of facing different dilemmas, you can often feel like you're all alone in this fight, but you're really not. There are thousands of patients who have gone through what you have gone through. So having that support group make you feel that, others have experienced this. I'm not crazy. I'm not the only one thinking this way. I'm not the only one experiencing this. And just as one person on here may have a suggestion, that support group is important, because others can tell you, this may not work for you, but here's what works for me. And you may have to do that trial and error to figure out, I may not be able to drink as much as someone else, but as Nancy said, what you eat and drink really matters. You don't want to be bloated. You want to understand that something else is better for someone, but you may have to stick to what makes you comfortable, what works for you. Minimizing, if you're on dialysis in center, then you have 24 to 48 hours to gain, it's like 48 to 72 hours, depending on whether it's 2 days or 3 days between your dialysis treatments. Remember, you're not going to be dialyzed for those 3 days, so your fluid gain, like for instance, there's a holiday coming up this weekend. For those of you who dialyze on Monday, unless you have an extra dialysis on Saturday, you will go 3 days without being dialyzed if you doubt. So in those situations, you put yourself at jeopardy, because now if you're not making urine, you will gain more than your norm. So you have to be careful about what you eat and what you drink, especially if the weather is warm. If you're not going to sweat it out, and if you're not going to urinate it out, then the only way it can come off is by dialysis, by the dialysis machine. So if you have any underlying heart disease, then you could potentially put your heart in jeopardy by developing congestive heart failure, because now you've accumulated so much fluid on your system. Even you may not necessarily be drinking, but even in the things you may be taking in, you take watermelon, cucumbers, vegetables, things that are mostly water, they're going to act as fluid, and that is going to overload your system. So those are things that you have to consider. If you're drinking soup, that's liquid. If you may be drinking a shake, but that's also liquid, a semi. And so those fluids have to be taken into consideration. Eating ice chips becomes water. So all of those things you have to think about, especially as it gets hot outside. Sometimes we suggest use frozen grapes to really quench your thirst, especially when it gets hot. So be conscious of your intake, especially if you have to wait. So stick to your fluid restriction. Find ways to really accommodate your intake, and make sure you're watching that carefully. When you come off of dialysis, sometimes we're often very thirsty. We feel lightheaded because now you've taken off 8 pounds and you're drained, and you feel like you need to drink so much to feel better again. So that can be difficult. Most transplant patients seem so happy and carefree after transplant. How can this encourage others to get a transplant? you know, transplant, I will preface, is not for everyone because of the potential complications based on age, the risk benefits, and you have to look at sometimes patients are not great candidates and they feel that they've been denied a transplant, but oftentimes it's because the risks outweigh the benefits in terms of saying, well, this patient may not, I may give you a transplant, but you may not be alive in a year or two, or you may be dead in 6 months, and that's not our goal for doing that to you. Our goal is to be able to expand your lifespan, to lengthen your lifespan. And so the goal is to take that person who passed through their workup, got their transplant, and for many of those patients, they are now able to avoid transplant, avoid dialysis. The goal when I was in transplant was to take some of those patients back to the dialysis unit so that others can see that despite what they went through, sometimes patients in the dialysis unit only hear about those patients who died after transplant, or they only see those who didn't do well and had to return to dialysis due to a failed kidney. So it's really important to see the successes and hear about the successes so you can know that 95% of patients to 98% of patients do well in the first year after transplant. The goal is to avoid rejection, avoid infections, and to know that if that percent of patients doing well, that you may be included in that percentage. And so I use patients when I was going out to give talks to encourage people about organ donation, for churches, for community centers. Nothing speaks more than the testimony of someone who has gone through the process. I can tell you all the positives about it. I can tell you what I see in the patients, but what works best is having the testimony of someone who's gone through it. What works best is having presented donors who were able to donate to their loved ones, can talk about their experience, can talk about the good and the bad. Patients who've had transplant who can talk about, yeah, I had a difficult course. This is my third transplant. My first one didn't work well. My second one lasted a short time, but now I'm doing extremely well. And yes, I would do it all over again, even though I had to do it 3 times. Yeah, you may experience rejection. There are patients who said, I wish if I had known all of this, I might not have done this. But those things are not necessarily predictable. The goal, I don't even know have a golden, a glass ball. Our goal is to look at that donor and its potential for success, for working, match it with the right person. Not all kidneys will work right away. Those that even I know may not work right away, I may choose to give you because I know based on that donor that this kidney will wake up. It may take a week or 2, but I'm confident that it's going to wake up. Oftentimes that may not be true, but that may be only 1 in 25, 1 in 50 or 75, where it doesn't necessarily do what you think it's going to do. That's why we biopsy. That's why we sometimes will deny a patient a transplant because I looked at it and it didn't look so good. I biopsied and it's a lot worse than what I thought. So what are the concerns of taking a high-risk kidney? Generally, the KDPI is a score that's given to each donor based on age, based on underlying disease factors such as did they have hypertension, did they have diabetes. Oftentimes, if those 2 things exist, there will be a biopsy of that donor because family members will tell you, oh, they had diabetes for 10 years, but that's the 10 years they know about. They may not live with the person and they may underestimate that. And maybe it's 20 years. So oftentimes there will be a biopsy of the kidney to decide if there's less than 20 to 25% of scarring. Not everyone with diabetes will necessarily develop kidney disease, and not everyone with high blood pressure will have kidney disease, but we do want to biopsy to make sure that there isn't Oftentimes the biopsy is a frozen section, so it's not 100% accurate, but we do go by the amount of scarring that can be seen on that frozen section. So if that we would not give a donor with diabetes to a recipient with diabetes, because we know that there may be some changes in that kidney from diabetes, and that may be a double whammy. We want to know how the donor, was it a traumatic brain injury? Was the donation after cardiac death? So the high-risk kidney is often those that may be older. The chances of recovery may be a little lower than someone of a younger age. And high risk, as I said before, can often be a donor with hepatitis C positive antibodies, not the virus. If the person tested, you just use hepatitis C positive donors, presence of the antibody, which means that donor likely had hepatitis or been exposed to hepatitis C in the past. Most families don't even know that has existed. And oftentimes, if it's negative, if it's positive, you can still use those kidneys for donation, with the understanding from the recipient side that if they're develop hepatitis C, they will immediately begin a treatment for hepatitis C as soon as you turn positives, and those drugs are effective. The danger is there are many strains of hepatitis C, and it may be possible that there is a virulent strain that doesn't respond to the current antiviral treatment, and that you may not be able to get rid of that hepatitis C. But that's very, very rare. I don't think there's very little data showing that happens. I can't accurately quote you the numbers, but I know there are thousands of patients who have received hepatitis C positive kidneys, as well as many patients, as I said, with liver transplant who's gotten hepatitis C positive. Danger is kidney doesn't work. You continue on dialysis until it kicks in. And that's with any kidney. High risk, generally depending on your age and the donor's age, you have to decide with your center what is, if you are in your 40s, do you want to take a 60-something-year-old kidney? If you're 20, probably not. And so the age, just remember, the older we get, the more age those kidneys are. I would love to donate my kidney, but at my age, probably nobody wants it, because they want that. You want to be left with a kidney that will last you for a good long time. And if my kidney function is only 60% with 2 kidneys, then if I give one away, then you as a recipient may get a kidney with only 35 or 40% kidney function. Can that last you, long time? Well, yeah, if you're in your 60s, probably. If you're in your 20s or 30s, maybe not. If you get rejection and complications from virus infections, that may throw it over the edge. So those are things you talk about with your surgeon or your transplant coordinator in terms of what you're willing to accept based on your age, how desperate you are, and as well as whether it's your first, second, or third transplant. So I've been rambling. I hope you guys enjoy the conversation. We are at the hour. It's been 30 minutes already, and I hope I answered everyone's question. Thank you so much. Have a wonderful weekend. Stay cool, stay hydrated. Wear your sunblock and your suntan. Keep your arms and ears and head covered if you are immunosuppressed, so you decreases your risk of cancer if you're out there in the sun, in the hot weather, and during this heat wave. Have a great one and enjoy.